Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Welcome back to Unraveled. David Kaufman and my
Eileen
friend and
Ruhoy.
colleague.
Hi. We're a duo.
Yeah. So, as you know, we choose topics which we don't plan for, which probably shows every time we do this.
Sometimes we'll read comments from subscribers and we'll think, oh, that's a good topic to cover.
Right.
And in fact, in our recent venous congestion webinar, in the question chat group, we were commenting on, oh, these are good topics for a podcast. So,
and I asked them if they would save all those questions.
Did they?
They said they would, but I haven't been able to get them.
Okay, well,
because they were good topics.
I'll write the organizer and see if she can send us the questions. Yeah. But so today's topic
is CSF leaks, spinal fluid leaks, a important and tough topic, which will bring us into both intracerebral hypotension and hypertension and EDS and brain fog and symptomatic misery.
Absolutely. And what symptoms will happen and what the history often will consist of. And I think that's an important piece because very often with patients with CSF leaks, they can tell you when their headache either started or changed, right? A lot of our patients, of course, have just a long history of headaches. I mean, headaches since they were children. But they will tell you that at a certain point in their adult life, usually, that the headache quality and the severity and the frequency had changed, where it usually becomes what we refer to as a chronic daily headache. And when you ask a lot of questions, oftentimes they don't know what might have triggered it, but if you ask enough questions, sometimes you can guesstimate, there was some abrupt movement maybe, or even like, oh, I had a fall the day before, or I had a viral illness, or, I was sick or whatever. So you can sometimes sort of try to understand maybe how this happened. And sometimes you just don't know at all. It just happened. But if a patient doesn't have a history of headaches, I very often get a story of, I heard something pop, or I fell and I heard something crack, or I had this acute, very focal pain at this point of my back. So you'll get that kind of history, and then you start to think about a CSF leak. I recently had a patient who was singing karaoke, and she was trying to hit a high note, and trying to hit that high note, she felt something snap in the back of her throat. And then she's had pain since, and it's been like 5 years, and no one can figure out what's going on. And I thought, CSF leak until proven otherwise. Right. So I think we always talk about how important the history is.
I was just about to say that. Yeah.
And I think this is one of those diagnoses where the history can be super critical, but you don't always find the answer in the history.
Yeah. I mean, I was about to say the same thing, that a perfect example of how important the history is and how important it is to obviously listen to what the person is saying, but really listen. Mm-hmm. So too often in those 10-minute, 20-minute visits to the clinic, a patient says, oh, I heard something crack. Most doctors will say, oh, come on, you can't hear your brain crack, or whatever version of that. And so history, but also an index of suspicion.
Correct.
If you don't know about CSF leaks, if it's not in your brain trust, you're not going to diagnose it. You're not going to consider it. So index of suspicion is so key.
Right, and I think in headache medicine in general, this is what we refer to as secondary causes of headaches. It's not sort of front line. It's not always on the first thing that a neurologist thinks about, and nor should they, frankly. It's still considered somewhat rare and exceptional, and not a very common cause of headaches. But I can't help but think about our skewed patient population, and it's not that uncommon. In fact, it's more common in our patient population, and we know that connective tissue disorders does put you at risk for CSF leaks. The meninges are connective tissue. And it also puts you at risk of just elevated intracranial pressure, which puts you at risk of popping a leak and then having
Right.
intracranial hypotension. So I think our patient population are just at greater risk, so we just tend to see it more often, but headache medicine in general doesn't focus in
Right.
on
So
this.
along those lines, I think another way of saying what you're saying is in our population of patients, there are a dozen reasons to have a headache, not just a spinal
Right,
fluid leak. And so
right,
it can be very confusing. And of course, there doesn't have to just be one reason. They can have hypoperfusion from
correct.
POTS, and they can have a dural leak because they have connective tissue disorder, and they can have a history of head and neck trauma. And it just kind of builds up and up and up.
Yeah, that's a really good point. There's a lot of reasons in our patients why there could be headaches. And I always say that if you have a migrainous brain, which means you've had a personal history of migraines or you have a significant family history of migraines, then any reason for a headache or any reason for a change of physiology of the brain can lead a migrainous brain into a migraine. And so sometimes to take a history of the migraine. I mean, I know for me, for example, when I knew that something was wrong, I was told over and over and over again, well, you have a history of migraines, kind of thing, as if that was that was my diagnosis. This
Right.
was all migraine. And I kept saying to them, no, my history of migraines is like 1 or 2 a year. Now I'm getting like several a month. And to me, now looking back, that was a key point of my history that no one, sort of focused in on. No one
This
did.
is such a common problem in
Hmm.
medicine, and it's something I talk to patients about. Not related to your headaches and your history, but no, seriously,
Right.
but it's worth spending a second, and it's a little off the topic
Tangent.
of
Yeah, but that's
CSF,
okay.
but that's all we ever do, so it's okay.
We'll get back to it.
And I used to use this was very common when I was doing HIV medicine, and recently it's happened a lot, frequently in ME/CFS long COVID medicine. The danger is that you as a patient, you as a family member, or your physicians will attribute every complaint and every problem to your now known diagnosis of, let's say, long COVID. Okay? So, as an example, I had a patient on a telemedicine call the other day, and she tells me her blood pressure is high. How high? 180 over 110, and she's describing chest pressure and chest pain. That's not ME/CFS long COVID, at least not until everything else is ruled out. And I
Right.
had to convince these people, this family, that this is, from my perspective, this is cardiac until ruled out. You have to go to the emergency room, to an urgent care. You have to be looked at and have an EKG and check this out. And I've seen over and over that mistake made by physicians and patients. Oh, it's my long COVID.
Right.
And the same thing happened back in the HIV days. People get chest pain and cardiac events. They get pulmonary emboli, and they may not be related to their bigger diagnosis. So.
That is very true. And I think that even a lot of functional medicine doctors, they do make that mistake. And, sometimes when I'm telling patients they need to go see another specialist or they need to go to the ER, like one of their doctors might call me and say, that's not necessary, kind of thing. And I'll say that might be what you think, but I just need to know for sure that I'm not missing anything because I don't want to put any patient at risk
Right.
just because I'm going to put it all in this wastebasket. And that's what I will say that does concern me sometimes when patients are given a diagnosis of EDS, for example. Everything is put into that wastebasket. I had seen that done with fibromyalgia for many, many years, well before I got into this field of chronic and complex illness, that everything was related to their fibromyalgia, but the symptoms were concerning enough where I needed to be sure we were ruling things out. And I will also say that early on when I was in this space, started working in this space, when I went into private practice 10 years ago now, wow, it's crazy how time flies. But they would come to me having seen so many doctors, and I would hear certain symptoms and I would think, well, did we rule out A, B, and C? And they, of course, wouldn't know. And why would they? And, that's okay. So I would do certain workups to at least rule out certain other diagnoses. And I would say 20% of the time I would find a diagnosis that was missed and that had treatment, right? And so they hadn't been treated appropriately for a bunch of years.
Yeah.
So I think what you say is actually a very critical point, that we have to be sure that we're at least covering other things that we know as doctors and we're not putting patients at greater risk. I remember Dr. Navio once said to me, you don't want to be caught with your pants down. So I always think that, and I always make sure that I'm not missing anything. That is for sure. So with headache, and headache, by the way, there's this idea that somehow headaches are headaches, but there are very scary reasons for headaches.
Yeah.
And of course, CSF leaks being one of them. And it's because that they just don't, they are severe, they're debilitating. And CSF leaks come with other kinds of symptoms that really just sort of change the quality of life of patients and make them bedbound, make them unable to participate in fun activities of life and to have very poor quality of life. So it's an important thing to at least rule out. But having said that, it can be hard to identify a
It's
leak.
very difficult.
It's extremely difficult.
And I think, and we will explain why it's difficult, but in order to, so it's difficult to visually prove a leak, all right, and we'll get to that. And therefore, the accuracy of history, listening, and taking becomes paramount.
Yeah.
Because that becomes almost the only way to make the diagnosis, unless you start shipping patients off all around the country to these,
Right. Right. I
imaging
will
stuff.
say, though, that it seems that I just recently read an article that reported that 50 to 70% of the time, which is sort of a wide range, but an MRI with contrast of the brain can show some telltale signs of a spontaneous intracranial hypotension, which is currently what it's referred to as, if it's related to any kind of leakage or diversion of CSF. So it doesn't have to necessarily be a dural leak. It can be a fistula, and then it just goes into the venous circulation.
That's surprisingly encouraging information.
Yeah, I agree. I was shocked to see it that high because I
Yeah.
always thought it was lower than that.
Yeah.
But apparently you could start to see some of the telltale signs with an MRI with contrast, which, as you know, a lot of our patients, because of their mast cells, they don't want contrast.
Right.
And we tend not to want to order it because they can have a mast cell reaction and it can be hard to manage. But if you can get it with and I
So
will say that
let
they
me
tolerate the
make sure I
gadolinium
have
fine.
that, and let's make sure everybody understands. What you're saying is this paper says that an
It
MRI
wasn't one paper. Like, it was a couple of papers that were sort of talking about getting an MRI of the brain with contrast, and it seemed to sort of suggest that it's a lot easier to see these signs than what was initially
Okay.
thought.
So what that is also saying is that regardless of where the leak is from here to here,
That's correct. Yes, exactly.
you can see it in the brain
Spinal leaks I'm
if you
referring
look
to.
there and know what to
Correct.
look for with a contrast study. That's
Correct.
very important, because the
Yes.
problem that I've seen is finding the source of the leak is daunting, to say the least.
Right. The most common finding was meningeal enhancement, which is why it needs contrast, right? It's not
All
going
right,
to
well,
enhance
that's
without the
great to know.
contrast. Yeah. So you need to sort of convince a patient to
Yeah.
get gadolinium, which of course has its own set of issues, because this whole gadolinium toxicity thing is a big deal amongst a lot of patients.
Right.
And so and not that it shouldn't be. I think that there are reasons why a certain subpopulation of our patients, especially, are particularly sensitive to gadolinium. So it's something to obviously keep in mind, but you need the gadolinium.
Yeah, it's
to really
another
see this.
risk-benefit decision. I mean, yes, they're sensitive to gadolinium, but they're probably pretty sensitive to spinal fluid leak.
That's right. Well, they're suffering from
Yeah,
it,
that's
right?
what I'm being
That's
a
the
little
whole, right.
sarcastic.
Oh, that was sarcasm?
Well, it was, I don't know what it was.
Glibness.
Relativism.
Relativism. What are you, a physicist now?
Well, that's really interesting, because
Yeah.
I've ordered in the past many MRI myelograms, which don't use contrast, and I never find anything. It's so rare to get the
Right,
initial
so-
report showing a leak.
That is true. And it's interesting that different centers obviously have their own set of
Right.
imaging that they prefer. But it seems that it's useful to, at least we can first order the MRI of the brain with contrast, and we can see if there's any evidence of
Yeah.
potential, and there has to be a level of chronicity to it to actually see these signs. So it's not that it happened yesterday and then you get the MRI and you'll see it. There has to be a little bit of time of which it existed to have had these changes take place in the brain to see it radiographically on the MRI of the brain.
So why don't we back up a little and go over history?
Yeah.
And again, I would emphasize that there's specific history related to what we're talking about, and then there is the context of the history, the context that history is in, meaning, does the person have a risk for this possible diagnosis?
Correct.
And that's a concept that's just so important in the work in in all medical work, healthcare
Right.
work, but especially or also in our work, and I often use the example with Lyme disease. I want to know they have a risk before I'm going to pursue the diagnosis because it
Correct.
affects the value of the testing. So in terms of CSF leak, the context is, I'll do the
Yeah.
context, you can do the history.
Well, I've thought a lot about this, right? Because when you train in neurology, CSF leaks are not, you don't really learn a whole lot about them because they're thought to be rare. In fact, IIH, idiopathic intracranial hypertension, is still considered a rare disorder, which every time I read that, I think it's not that rare. And it's also still very much classified. I know I'm not answering your question just
That's
yet.
okay.
And I think that's a good exercise that you just laid out there, and we will do that. But I'm just sort of, I'm remarking on every time I think about the kind of neurology I practice now and the kind of neurology I practiced 12 years ago, or even the kind of neurology that I learned about, like I'm just amazed at how different it is. And sometimes it scares me, to be honest. Like sometimes I'm like, what am I doing? But other times I'm like, no, this is what I need to be doing because this is what these patients deserve and are suffering with, and so this is a perfect example of a diagnosis of which that whole thought process applies. Is that IH is still sort of classified as like fat women, which is so offensive
Yep.
on so many levels. And even there was a recent article about IH and sleep disturbances and talking about the prevalence of sleep apnea and the collapse of the upper airway, and it's because they're fat. It was the implication. And I'm paraphrasing, of course. But when you think about even connective tissue, as you know, I always say that it's not just about the peripheral joints. That Baton scale score thing
So
drives me
misleading.
nuts.
So misleading.
Right. It's so misleading because there's so much more connective tissue in the body. And when I think about, the pieces that are connective tissue, like, of course, the upper airway is going to collapse. And so, like, I just feel like there's so much that's misguiding and misleading other physicians from really considering other diagnoses and actually looking for these diagnoses and helping patients get treated for these diagnoses. I'm not sure how I got to where I am right now in terms of my talking.
I get it. I get it.
I'm so scatterbrained some days. But I just feel like we really need to sort of classify and listen to patients and really think through what is going on in their anatomy. And I regularly say this: anatomy changes physiology, sometimes physiology changes anatomy. And so to go back to your question, what puts them at risk? So yes, connective tissue disorders, it's not always EDS. Something that's degrading their connective tissue, they don't have to be hypermobile in a peripheral joint sense. If they've had chronic
I was
infections,
just going to say,
chronic immune responses,
years of chronic
inflammatory
inflammation.
responses, yeah, absolutely.
Mast
It
cell
will break
activation.
down the connective tissue. And we see this all of the time. All of the time. So there doesn't have to be any kind of Marfan syndrome or hypermobility in their history or even in their family history, but come to me with like a long story of, I've had recurrent strep infections. I've had mononucleosis twice. I was bit by 400 ticks when I was growing up in New England and hiking every weekend. My mother used to pick ticks off me, and we've all heard these stories. And so this, to me, that's a risk factor for a CSF leak.
Exactly.
And I know that I'm taking it a few steps, down the line.
But that's the point. That's the point I
exactly.
wanted us to focus on for a minute, because it's not just about the headache and the leak.
Right.
It's about why you need to consider it in what context. All right. And as you say, you went through it. I don't need to repeat it, but that's really crucial, because the more at risk the patient is based on their history of exposure or risk from the things you just went through, the greater the likelihood that the diagnosis you're considering will be true and that you can find it in testing.
Right.
And the opposite is just as true. If you just grab somebody off the street and say, oh, I think you have a leak, and you go test them, you're going to get negatives, or you'll get false positives. So
that's exactly right. And so if they have all those risk factors, you have to test them and then you have to treat them. But in the meantime, they developed a leak and they don't know it yet. And we don't know it yet, technically.
Right.
But they come to you and they say, I don't know. I mean, yes, have I had headaches in my lifetime? Sure. But this is different.
Right.
This is more severe. This is more frequent. Nothing is touching it. None of the over-the-counter medications, none of the prescribed medications, the CGRP classes of antagonist class of meds are not working. The triptans are useless.
So let's walk through the specific history that would make you as a neurologist suspicious of a leak.
Okay.
What does the patient say to you?
The patient, well, if there's a clear, like on last Tuesday, I bent down to pick up, actually a recent case that I just had in clinic this week. Her child was I forget the specifics, but was in his high chair and threw like a pudding cup or a sippy cup, and she abruptly went to go grab it or catch it, and she said that she felt something pop, and from that point forward, she had suffered. And then that was like a couple years ago, which is really the sad part. She had suffered greatly with headaches, with neck pain, with upper back pain, that coat hanger kind of pain that we attribute to POTS, which, yes, is sometimes absolutely true to what they presume is abnormal blood distribution just from the vasomotor dysregulation of dysautonomia. But this was, a clear like pain and spasms and pain that would radiate up to the top of her head, and nothing has touched it. And she's just gotten worse. And she's been told it's because of stress in her life and because she's overweight. And so,
but was there a positional aspect to her?
So it gets better when she lies down. So most of her life she's supine, and it gets worse when she gets up over time. And this is an interesting thing that point that I like to sort of talk about a lot, because I think what can sometimes mislead doctors is that they'll say, when I stand up, there's no greater headache. The headache isn't more severe when I stand. I might feel a little lightheaded. I might feel a little dizzy. Sometimes I feel a little nauseous, but the headache itself is not any worse. But it gets worse towards the end of the day. And that seems to be the evolution of a intracranial hypotension kind of headache, is that it's not necessary. If initially it's worse when you stand. But over time, that doesn't seem to happen as much or as severely as it did at the beginning, and it'll be more of what we refer to as the second half of the day kind of headache, later in the day kind of headache.
So let's talk physiology just for a minute, because I think it will help people understand what you're saying, because it's really crucial. Yeah. And any physicians that are listening to this, okay? You have a brain, you have a spinal cord, you have dura, okay? And let's say there's a leak. Let's say the leak is at L1. All right, or T12 for some reason. That leak is not a faucet. It's a pinhole, or maybe it's 5 millimeters.
Right.
Okay. And you're lying down all night and a lot during the day because you don't feel well. And during that time, the leak is not really happening very much because of gravity. Everything about our life is gravity. Okay, I'm serious. The more I think about gravity, is like evolution and disguise.
We'd be flying in space.
It's just and also we've evolved. Everything we've done in our bodies is evolved to cope with gravity.
Correct.
All right. End of diversion. Okay, you stand up, and now you have a column of spinal fluid coming down on top with gravity to L1 or T12, wherever it is, and what you have is a little.
Well, there are fast leaks and there are slow leaks.
But okay. Let's keep it slow, okay? So it stands to reason that it's going to take time for your brain to sag and cause symptoms. Okay, that's the point I'm trying to get to.
Yes.
It's not like you stand up and your brain goes poof and you're like in trouble. It's very gradual and subtle, or can be subtle, and therefore it can occur later in the day.
Right.
And that's too easily ignored by other physicians.
It is ignored.
And by the patient. They just think, I just did too much today. That's my PEM causing my headache.
Right. And they'll think it's dehydration. In fact, that's what a lot of doctors will tell them. You're dehydrated. You need to drink more. The classic recommendations for intracranial hypotension from neurologists are, is bed rest, caffeine, hydration, occasionally a medication called theophylline, though it hasn't been all that effective. So we don't really prescribe it much anymore. I sometimes do. Just because sometimes the patients are so severely affected and we're waiting for their appointments at the places that could help them, which, I honestly wish that I could train to be like a neurointerventionalist at this point in my career, because I feel like I just want to help patients more. Like I help them find the diagnosis, and then I'm like, okay, now I need to refer you, and then they have to wait months and they suffer. Like I feel like I wish I could just go in and fix it for them.
Well, I would take it a step further. I don't know, and I don't think you even need training. I'm going to get in trouble for saying this. Why can't you, as a neurologist who does LPs with your eyes closed, listening to music or whatever, why can't you do a patching? Why can't you do it?
Let's not put that out there.
Joking.
I have my eyes open.
I'm joking. Why can't you do a blood patch? Well, the reason you can't do it is because you can't get the blood. It's not, you don't do that. That's ridiculous if you think about it.
Right. Well, I'd have to buy some very expensive equipment.
Why?
Like fluoroscopy and stuff like that. Sort of, you can't do that blinded. I mean, I guess you could do a blind patch, but if you identify a leak,
No, I'm talking specifically blind patch.
Oh, well.
I mean, I'm getting way ahead of ourselves in this, what I'm saying, which is
you want to give me more,
you get
more
the
work
history.
to do?
Yes. You take the history, you are suspicious, you have an index of suspicion.
Right.
You home in on the actual history.
You're right, and
I have the headache. It fits the context of a leak. You can't see it on the scan. You don't know where it is. The next step often should be, a blind patch, which is not such a big deal.
No, and you're right.
And getting it done is a nightmare.
Right. Well, to be fair, there actually are a couple of neurointerventionalists in some of these well-known centers who are willing to do blind patches now, which
but why would I have to make my patient fly to Duke? That's ridiculous. You should do it.
Okay. Okay. That's another podcast.
All right. Sorry.
It's all right. But yes, so I forgot how we got off on that. But yes, so that's you're describing the physiology correctly, and that is exactly what happens. And also, you have to even try to visualize it even further. If there is hypotension and so gravity takes over and the CSF sort of pools in the spinal canal and doesn't circulate appropriately, there's less buoyancy, which is what the brain and the brain stem and the cranial nerve specifically need. So then now there's traction on the cranial nerves, right? So then you have all these cranial neuropathies, cranial neuralgias, as opposed to when there's elevated intracranial pressure, then you have compression of these cranial nerves, right? Which is why you get some of the symptoms that you get. Like you can have like a cranial nerve 6 palsy, for example.
So I really want to go into detail because this is so important. It's not just the headache.
No, it's not just the headache.
It's not just the headache.
No, it's never just the headache. And that is a very important point. The headache is what seems to bring the patient.
Exactly.
And the headache is what you can certainly first focus on because it's the most debilitating symptom to patients, and it actually affects their quality of life more so than some of the other symptoms. But if you take a good history, as we do or as we try to do, you'll find that there's a lot of other symptoms that are related to this overall physiology of either traction on these cranial nerves or too little buoyancy of the brain, so things are sagging, which is not a fun place for the brain to be. The brain does not want to sag.
Right.
Right. It doesn't. I mean, and when brains sag, I always say that anatomical malalignment, obviously referring more to the skeletal kind of malalignments, specifically in the cervical spine, for example, or other parts of the spine, but the brain is as well. Like if the things aren't in appropriate anatomical ratios of like where the mammillary bodies are compared to the pons, those kinds of things, like things go wrong. You have symptoms, and it doesn't necessarily lead to some like mortality concern, but there's a lot of morbidity. And it's because of the abnormal anatomical arrangement, I guess is the better phrase, that happens from the lack of buoyancy, from the lack of enough fluid. And then if there's elevated pressure, then there's too much fluid, and then there's compression, and it's a similar kind of physiology where now you have symptoms related to the compression. And so I think it's important to sort of recognize that these symptoms are not just the headache, but yes, the headache is what brings the patient to the doctor. But then there's we sort of covered this in that episode we did of like weird symptoms that patients are told that just can't be true.
Right.
But it's like, so dizziness or vertigo, patients will say that they're just sitting there and all of a sudden it's like the world is spinning around them. Tinnitus, it's often pulsatile, though it does not have to be.
Right.
And sometimes they'll say, well, when I lie down, it seems more pulsatile, which actually does make some sense. So it doesn't have to be pulsatile. It could just be ringing. It can have a different kind of quality. Like sometimes it's high pitch, sometimes it's low pitch. So there's no classic tinnitus that's related to pressure disorders. And then there's like a lot of atypical facial pain, intraoral pain, palate pain, teeth pain. I had a patient who had like 7 teeth extracted, and it was all because she had a CSF leak. Like it's the craziness that we see in clinic makes me cry sometimes.
Yeah.
Like I'm trying not to cry now thinking about some of these patients' stories, but it's just, and it's just sad. And anyway, I have to just take a break for a second.
It is sad, and it's on the other hand, I think CSF leaks are mysterious to most physicians. I practiced in New York for 30 years. I was just saying this literally on Thursday, walking back from the office. Where were all these patients for those 30 years?
They were being gaslit.
Yes, exactly. And I'd like to think that I was not participating in doing that. And I can say, well, I was mostly seeing HIV patients, so that's why I didn't see these people. But now it's all I see, obviously. And there's just thousands of these poor people out there who are undiagnosed. And is it that I missed it, or did they not come to me because I was called an HIV doc? I don't know the answer, but the point I'm making and rambling on about is there are so many people out there sick like this, and most physicians just miss it, not because they're bad physicians. There's zero training in medical school and postgraduate training related to these complex illnesses. That's what drives me crazy.
Zero training.
There's zero
Especially
training.
when we were in school.
Yes.
I mean, maybe now there's a little bit more.
No, there's
You
very
don't think
little.
so?
I mean, I'd like to show me a textbook in medical school. If there are any medical students, you can tell me. Is there any paragraph on long COVID? And is there maybe 5 sentences on ME/CFS? And we're talking now with long COVID, tens of millions of people in this country, let alone the world. I mean, yes, they'll all disappear now with the new administration and we won't know about it. But other than that, they're out there.
Well, to just speak to what you had sort of commented on, I have no doubt I participated in the gaslighting. And I know that I've brought up before, like I think of patients from like 15 years ago, and now I know what was going on with them.
Yeah.
And I wish I remembered their names. I don't. Otherwise, I'd reach out to them.
It's so much of the normals.
The
Are
normative.
not taking into account patients with connective tissue disorder.
Exactly.
And my answer to that is that's terrifying. And an example, again, of medicine and the problems, because we're not talking about a small population.
Right.
The statistic that's out there, which is probably wrong, meaning too low, is 1 in 5,000 have hypermobility EDS. 1 in 5,000. We have a country of 350 million people.
That's a lot of people.
How many people have EDS?
I know.
And yet their physiology, their structure,
It's different.
is not appreciated or recognized in research and in medical schools. It is now more. It's finally happening. So that you learned and I learned, that the opening pressure, if it's 25, that's okay. I still see. I get those reports from people all the time.
I see it all the time.
They
It's
said
normal.
it was fine. My pressure was
normal.
22.
Yeah. So about a year ago, I had a patient who is an EDS patient, and as a lot of my patients are, and I knew she had elevated pressure, and she did not have the classic papilledema, although she did report some visual disturbances, but she had severe headaches, where she was actually hospitalized for them, and they were giving her migraine treatments, which again, I never argue or complain because some of those medications can take the edge off the headache. And so I'm like, let's give it a try. But it wasn't getting better. And I would talk to the team about my concern of her elevated intracranial pressure. But they said that they had done a lumbar puncture. They used manometry. They said that the pressure reading was normal. I said, well, what was it? They said 21. I said, okay, well, I don't think that's normal for her. And I said, can we treat her with like acetazolamide, methazolamide, zonisamide, topiramate, Lasix? These are the medications that we use for elevated intracranial pressure. Sometimes it's very hard for these EDS patients with their MCAS to tolerate a lot of these medications. Most of them are sulfa drugs. They can't tolerate that. You have to monitor the potassium levels and the acidosis, alkalosis. I make patients drink baking soda just for the bicarb. But there's a lot of management that goes on. Sometimes on an inpatient basis, they don't want to do all of that kind of extra work, which is fine. But I said, let's just start it and see if she responds. She didn't respond all that well, didn't tolerate the drugs, didn't feel good on the drugs. I ultimately convinced, I happen to have, this is a weird story, but this patient was in Illinois. And the neurosurgeon on her team that was sort of evaluating her for like a CSF leak and things like that happened to have been my neurosurgeon. And so I convinced the team to actually put in a a lumbar drain. And so, and her headache resolved by just draining the fluid, right? They didn't want to do a high volume tap. I forget reason why. This is over a year ago, but they did put a lumbar drain in, and her headaches improved. And so, they took that as evidence that she had elevated intracranial pressure, and went looking for reasons that could contribute to it. Found some stenosis and stented and stuff like that. So, my point being is that sometimes it just takes like a little bit of suspend your disbelief for a second because of the indoctrination that takes place in medical schools and in residency, and just give the patient the benefit of the doubt for even like 20 minutes.
Yeah. So, and that goes hand in hand with what you and I talk about all the time to our patients, which is, unfortunately or fortunately, what we do all the time is trial and error. You have a headache, might be high pressure headache. Let's try Diamox.
I do it all the time.
Let's just see. What's the downside? There's not a terrible downside.
That's exactly what I say.
I'm not suggesting you try chemotherapy. I'm not suggesting you try radiation. Just a little Diamox. And it might not work, and it'll be my fault. You can blame me. But so much of what we do is trial and error. But the difference is that in training and education, you're told not to do trial and error. You have to have certainty. It's one of my big things, okay? We're taught certainty, which is like a joke. It's like saying, I can't even think of an analogy. It's so absurd to talk certainty in terms of medical situations and our health. We need to tolerate uncertainty. The patients need to tolerate uncertainty and take off from there in thinking, listening, and making decisions.
But that's an excellent point. You have to be comfortable in a place of like just not knowing the exact answer, but feeling confident that you understand and know enough to at least know what the next steps to try are. And I think that a lot of doctors don't like being in a place of uncertainty. Yes. Somehow we feel like we need to be certain about everything we say and do. And I think sometimes if you're uncertain in your head, and I'm not even saying intentionally, but you sort of turn it around and think, oh, well, I don't know the answer, so it must be you, right? It must be the patient. It must be you must be not explaining it correctly, or it might be stress or anxiety or depression, or you're not sleeping well, or whatever it may be what goes through the head.
There was a great essay or op-ed piece, or I don't know what to call it, in the New England Journal of Medicine, of all places, on uncertainty, which I still keep on my computer desktop. I'll try to post it and see if I can.
That's a great idea.
It's a great paper, and
we should definitely
I literally go back and read it a couple of times a year. It's just so important for us.
It's okay to be uncertain, because how else are we going to learn if we don't say, I don't know right now, but I suspect A, B, and C, and this is how I'm going to suss out A, B, and C, right? These are the steps that we're going to take. We're going to try this medication. We're going to order this test. We'll see what comes back, and then we'll decide on our next steps. And that's what I do every single day of my practice. That's exactly what I do with patients. And I think that they trust me enough to just say, okay, I'll do what you tell me to do. And I appreciate that. And I take that seriously. So I think uncertainty, you just have to get comfortable with being uncertain.
Right.
Because there isn't always the answer. Anyway, back to CSF leaks. It's actually a perfect topic because in that regard of uncertainty, because we don't know a whole lot. We're learning as we go. We're learning that it's a lot more common than we thought. We're learning of what our risk factors are. So risk factors are definitely connective tissue disorders, elevated intracranial pressure, because then you can pop a leak, and then just other kinds of, I think, like arterial venous malformations, like other venous abnormalities. I even think that a chronic vasculopathy or chronic vasculitis can put you at risk of these dural venous fistulas, right? So where the CSF fluid then just goes into the venous circulation, it's taken out of the spinal canal and goes into the venous circulation, and so it's not technically a leak. And it's fixed differently than a leak is. So you have to look for those as well. And I fully admit, I'm the first one to say that I don't know how to find those. I can't read the imaging well enough to pick up on those. And that's where those centers are really useful, by the way, because that's what they do.
I wasn't putting the centers down.
Yeah.
I just meant you have to get there.
Right, you have to get there. And they have to be accepted. The patients have to be accepted.
Right.
So, and I make a lot of referrals to a lot of the different centers. Obviously, my favorites are Duke and Cedars-Sinai, but Georgetown has a really good group there as well. And there's a couple of others that I also have been referring to recently. But I think, to look for the reason why there's low pressure in the spinal canal is a really important thing to do. There can also be a cranial leak, by the way. And that's an important thing that can be picked up on. Well, one, you can do the MRI with contrast. If it doesn't pick up on a cranial leak, then a cisternogram is often what's required, where there's actually an intrathecal injection of contrast, and it goes up over the brain.
Right.
And if it doesn't go up over the brain, then the presumption is that there's a leak, because then the fluid is not appropriating throughout. So, and not every center does cisternogram, so you have to.
Yeah, and it's a little nervous injecting contrast in.
Yeah, I agree. I mean, all these kinds of imagings obviously are not without risks.
What do you think about the so-called FLAT test?
The FLAT?
FLAT?
F-L-A-T?
F-L-A-T.
What's the FLAT test?
So this is from Stanford, guy at Stanford, I think Ian Carroll, where he tells people, and I've had patients just do it on their own. They find it online, of course.
Yeah.
You lie in bed for 48 hours.
Oh, yeah.
And you don't get up. I don't quite know how anybody can do that. I'd be worried about them getting a pulmonary embolus, but nevertheless, 48 hours lying in bed, and then and your headache is gone, and then if you stand and you get a headache, that helps make the diagnosis.
Right. I mean, that's sort of that was sort of the classic thing that, we had. Oh, I never knew it was called the FLAT test.
Yeah.
I mean, has it proven to be, what's its sensitivity and specificity?
I don't know.
Because did you see that article that Dysautonomia International recently published that showed that the tilt table testing is superior to the NASA lean test?
I didn't see that.
Yeah.
I want to see that.
Yeah, I'll send it to you. I think the point. I mean, obviously, things that patients can do at home are very convenient and very useful, and at least start to sort of.
Actually, I got to say something. I haven't seen the paper. Okay, my problem is not with the tilt table test.
Oh, I know it's
or
not.
the autonomic test. My problem is the way it gets reported out and interpreted. And I think sometimes the audience thinks we make these stories up. Oh, I had a patient yesterday, but it's true. These are not made up stories. I had a patient Monday, I think it was Monday, who obviously has POTS. Okay, I mean, I don't have to measure it. I just talk to her. She has POTS. I can tell.
Right.
So she had a tilt table test, and on the tilt table test, her heart rate went to 26 beats, 25 beats above baseline. And while she was tilted, she was nauseous, dizzy, and felt very, very faint. And the report says the patient does not have POTS. And I get insane. I mean, I want to rip my hair out and start cursing and screaming. And I don't have any, luckily. And that's my problem with tilt table. I mean, because they go there, they spend a lot of money to get the test done, or the insurance does. It takes a lot of time. They have to get out of bed and go there, and often that's hard.
Right.
And then it gets misinterpreted. It's like the person on the tilt table is just a piece of wood. They don't care what that piece of wood feels. All they care about is what the heart rate did. Sorry.
No, don't be sorry. You're absolutely right. I mean, these kinds of testings, of course, are very objective. They're very methodical. They're very scientific. And so the reports that come out, I mean, as you know, I have this machinery.
Yeah.
And so the report that comes out is it's very cold. It's like, you're right. It doesn't take into account that there's a human that was strapped to this table.
I have no problem with that. But it's the doctor.
Well, because the doctor now is unfortunately required to report what the report says. I think when I have that report, I will write out like how the patient felt during the course of this test, and then I will say things like, I still highly suspect.
Exactly. That's the way you
high
should do
clinical
it.
suspicion of POTS, regardless of the fact that it didn't meet 30 beats per minute. So I think that, you're right. I think it's the doctor interpreting, sort of taking some leeway with regards to the patient and how they were feeling during the course of that testing. Because I think the symptoms are actually just as important as the measurement of the heart rate. I agree with that. But apparently it's a little bit more accurate than the lean test.
All right. How did we get off on this topic?
Because you were talking about the flat test, which I didn't call it the flat test, but I...
So, I mean, I don't know the specific sensitivity and specificity.
I'm curious if
and I just,
if Ian
to me, it
has done a
seems
study.
kind of unrealistic.
Well, if
to
you,
expect somebody to stay flat for 48 hours.
yeah, I mean that's hard.
Yeah.
But if they don't have a headache when they're flat, maybe they welcome it.
Yes, but does it really take 48 hours to make this diagnosis?
I think the 48 hours, the gravity that you are so in love with, I think it takes for the calibration to occur where I bet you the 48 hours increases the sensitivity of that kind of testing, right? So
Well, I'm sure it
right.
must.
So that's why it's 48 hours.
Yeah. All
But
right.
that was always the treatment for intracranial hypotension, like bed rest, caffeine, hydration.
Right. Okay.
So, but yeah, I never knew it was called the flat test. But that's just interesting. So yeah, so I think, so right. So then you do the imaging, and if you can find a leak or a fistula to at least explain the low pressure, then you have an answer, and you try to fix it. Though sometimes it requires several different fixes. And then sometimes you fix it, and now you have rebound hypertension, and then you've got more problems. You've got other kinds of headaches.
Which happens way more often than
Way more often.
I would have expected.
Yeah. I think, again, I think sometimes I feel like anatomy and physiology, which is why there's a whole class in med school, anatomy and physiology, is so much more complex than a lot of people give it credit for. And sometimes I get so frustrated when I see, like snippets on social media of people just talking about like causes of things. And I think it's so disrespectful to the complexity of the physiology of that particular system. It's very complex, and I think we don't understand most of it, frankly. I mean, I know we don't understand most of it, and we're learning, and we need time to learn. We need time to sort of grow our opinions and theories on this and to test them. And it's not easy, and for anyone who thinks that they just know the answer to how we're going to fix this, I think is just a little folly. And anyway, so I think it's important to listen to patients and take a really good history and understand the quality and quantity of their headaches, and understand what all the different potential contributors are to that headache, but also recognize that it's not just headaches, that it can cause a lot of other symptoms because of either the lack of fluid or too much fluid. And I think that's just, and that the patients deserve that. They don't deserve you just, doctors saying, oh, you have a headache, you have a migraine, here's a triptan, here's some Maxalt. Because you're also related to mast cell activation, as you know, histamine.
Sure.
There are histamine headaches, and patients will often say to me, when I take an antihistamine, the headache goes away. So that's a telltale sign.
Yeah. Not
That's the other thing, by the way.
necessarily of a leak, though.
No, not necessarily of a leak.
Okay.
But I will also say, though, mast cells do not like compression, right? So if there's too much fluid, or if they're sagging because of too little fluid, so that when the brain sags, like everything just, like the posterior fossa, everything just comes into that foramen magnum and just sort of sits there and is all squished. Those mast cells don't like it. They don't like mechanical compression for any reason. And so they will react in kind, if they are compressed on any level, and they can be compressed also from too much fluid. The fluid compresses everything, including the cranial nerves, for example. So so I think it's an important diagnosis not to miss, and that's all I have to say about that. To quote Forrest Gump.
Well, I mean, as we're ending, I want to again say that imaging is often frustrating and not as helpful as we would like.
Yeah.
I really want to read more about this thing, MRI brain with contrast, because that's new. I didn't know that.
Yeah, I mean,
and
does require contrast.
But I've looked, and it's so hard to get a positive result on looking at the cord. Doing a non-contrast MRI myelogram.
Yeah, you can do a hyperweighted T2 hyperweighted, and then you could do there's certain fat saturation spin echoes. So there are some fancy sequencing that can be done that can increase the sensitivity of a leak, and I don't pretend to even know how to read those specifics here. I just know that those are ways of doing it, and a good radiologist, a neuroradiologist, if you tell them that you're trying to see if you can identify a leak, they can help in that regard with the right sequencing. But it is very complicated.
Let me go back to the blind patch for a second, okay? So my question is, and it really is a question to you as a neurologist, we have a patient that we have a high suspicion that their symptoms and history are consistent with a leak, and we can't find the leak. What are the risks of doing a blind patch? I feel like whenever I consider it, I can't get most people to do it. They don't
Yeah.
want to do it. They think, and I'm not understanding, or maybe I'm just missing. What's the big deal here? Why is this such a difficult procedure to get done?
Because the truth is, if there's no leak, it can actually make the symptoms worse. So blood is actually very irritating to neural tissue
Right.
in general. And so if you don't have a leak that you need to fix, then doing just a blood patch can actually create a lot of inflammation and then create sort of a weakness of the dura. So, and it could also create a lot of back pain. It can actually make the symptoms a whole lot worse if you don't technically have a leak. So that's why a lot of doctors, or a lot of neurointerventionists and neurosurgeons don't want to do a blind blood patch.
Okay.
But if the history is highly suspicious of a leak, then you can get them to do it. And because they would agree that what else can cause these kinds of symptoms other than a leak, frankly.
So, and just for people listening, why does how does the patch work? Why is it effective? I mean, I think I know, but
Yeah, I mean, well, obviously it patches up the dura, the hole in the dura, and then
yes, but how? I mean,
it creates an inflammatory response. That's the whole
that's what I'm
point.
trying to get at.
Right,
It's that same
You're leading the witness. Is
yeah,
that what
I'm
you're
leading
doing?
the witness. Exactly.
You would have been a horrible lawyer. It's a good thing you became
Who
a
knows?
doctor.
Maybe I'd be a good lawyer. I don't know.
No, it creates an inflammatory response, and that's
Right,
how it
that's how it
patches
works.
up. Right, and that's why if you don't have
Yeah.
a hole to
Yeah, that makes
patch,
sense.
then it can make symptoms worse. So,
Okay, interesting.
all right. So, any other questions?
No, I'm going to shut up. I'm going to go to law school and fight.
You should actually. You would see. Then you can have some role in trying to fight off things that you're complaining about constantly. I created a monster on social media.
You did. Good. All right. No
Okay.
politics.
No
Try anyhow.
politics. All right. Well, thank you for listening to this. Hopefully, this made sense to people who were listening. I
think
feel like we
were
were all
in
over the
rambling
place.
mode today.
Yeah.
Very
I think
single.
I think we covered the important points about how the history is super important and the symptoms are critical, and then just even how to work it up and to think about it sooner rather than later in certain patients who have risk factors of popping a leak, frankly, or creating a fistula. So I think I think we did cover that at least in between our ramblings.
Yes.
Okay.
You can skip pieces. You can.
We have to timestamp?
The timestamps with the transcript.
Oh.
If they,
I didn't pick up on that.
If you just say show transcript, it's all timestamped.
Nice. All right, then. There you go.
We're learning YouTube.
I know. We're getting good at it. It's fun. All right. Well, thanks for listening. Tell all of your friends and family and doctors and other patients to subscribe, because the more popular we are, the more we are allowed to do on YouTube, I think, right?
Well, supposedly the more popular, then you get more. Some algorithm makes you even bigger. I don't know.
Right, exactly.
But
we're
we want
shown
people
to
to
other
find
people.
out about this. So
Yeah.
subscribe, hit like, which I hate.
Hit like. People do that. Hit down below.
Yeah, right.
I was going to say something else. One last thing.
And send us questions.
Send us questions. We're going to post a live soon. We're taking down the Patreon page in a couple of months because people keep just signing up, and I keep refunding their money, and so we're going to take down the Patreon page soon because.
But we are putting all of the Patreon
we are.
on YouTube.
Because Dr. Kaufman figured out how to do it.
I figured it out, but it's like 60 plus episodes, and it takes
a long time.
So
we're getting there, and you'll start seeing them pop up on the YouTube page. But when we're done, we're going to take down the Patreon page, just so you know. But we will be announcing our live soon. We have to come up with a date. So get your questions ready because we love those questions, and we'll see you soon.